I'm not going to use the podium. You can hear me well, right? Okay. So I have no conflict of interest with this lecture. And you know, every 5 years in Mexico, we have to get recertified by the board, as in here and other countries. And normally people would do it through points, CME points. But sometimes people don't get the CME points and they have to present the exam again. And there's also an option to do the exam in simulation if you meet some criteria. And that is how I met Gabriela. And I'm going to tell you her story. For Gabriela, it was a different situation. You see, Gabriela was her first recertification. This meaning that she just had 5 years since she finished her residency. She didn't get the points, so she presented the exam 3 times and didn't pass it. And her job was here, you know, she might lose it. So they sent her to simulation to see what happens. No, how was she doing? And she came very nervous, like she was very, very nervous. And I'm sad to say that she didn't do well, and she didn't pass. So I had to get out there with a couple of colleagues from the board and sit down with her and tell her, you know, you didn't pass. And obviously she started crying. The other 2 guys left, and I stayed with her just to listen to her story. And well, she told me that she was from another state. She worked now currently in Oaxaca. It's a state in Mexico. She found a job after finishing her residency in a rural hospital. And she also told me that she was a single mom. She had a 4-year-old daughter. And that is why she couldn't meet the points. You see, for her, traveling to the city to, you know, for a conference, it was hard. It was expensive. And it was pre-pandemic, but we don't have enough points for online learning also. So, you know, imagine traveling, leaving her daughter with her family or whomever, then go to the conference, then go back. And that's why she didn't pass. And I remember that she looked at me and she said, I just didn't have the same opportunities that you all have. I felt terrible. You see, I was used to judge. I was used to judge from my privileged position. I work at a hospital that was founded by the American and the British communities in Mexico in 1886. It is well funded. It is a private hospital. It is Joint Commission certified. That meaning we have processes. We have access to medications, monitors, you know, whatever. And I understood the clinical part. You know, during the residency in anesthesia, we have to do 4 months rural, mandatory. So I lived there, you know, I knew the situation. But I never thought about it from the educational point of view and the impact that you can have. And you see, these opportunities or not access to opportunities is inequality. That's its meaning. And we grow up looking at inequality as something you see every day. It's normal, okay? But it's not correct. And actually, if you see the statistics from the World Bank, Latin America has a big problem of inequality. The top decile earns 48% of the total income of the region. 48%. And just the poorest decile, just 1.6%. It is huge. And there's a Gini coefficient. This Gini coefficient reflects inequality. The higher, the better, or the lower inequality. And Mexico is 45.4. So we're below the middle. We're not the worst country in Latin America, but certainly we're not doing great. And you see, having opportunities is like Spider-Man. Behind great power comes great responsibility. Behind great opportunities comes a huge responsibility. And I've never looked at it like that until I met Gabriela. And at the hospital, we know that. And from the clinical point of view, we work, we have the inclusive health programs. And this is a very interesting area of the hospital because ABC Hospital is private. Patients pay to be treated there. Well, usually they're insurance companies. But here what we have is at the same hospital, it's not an out clinic. We treat patients in vulnerable conditions so that they don't have access to healthcare, whatever. It can be a consult, it can be a heart surgery, neurosurgery, whatever. And these inclusive programs, last year we treated almost 5,000 patients. The investment that the hospital gives, it's around $20 million, just 1 year. So it's it's a very interesting model. And this works with donors in the hospital giving the resources and staff working for free. So we have that, or we think we have that social responsibility area solved. But, well, we need to look at the educational part. But let me make a parenthesis here and talk to you about anesthesia access in Latin America. So you see in 2017, the WFSA published this paper. And it's a survey about the workforce of anesthesia in the world. And Latin America is like this. We have countries like Brazil, like Argentina, like Mexico, and we have over 10 anesthesiologists per every 100,000 inhabitants in that country. But we also have countries like Honduras, like Guatemala, like El Salvador, where they have lower than 3. Actually, Honduras has just 185 anesthesiologists in the whole country, so it's less than your staff. And El Salvador has 150 for the whole country. So there's also a huge inequality in Latin America. But okay, in order to understand globally, let's think individually, and I'm going to share with you another story, and this is the story of Luis. So I met Luis in the same circumstance that I met Gabriela. They sent him to us to get examined in simulation. But Luis's situation was different because it was his first certification. This meaning he just finished his residency. Actually, he finished it 2 years ago, but hadn't been able to pass the grading exam. This is the first time that we had somebody like that. Okay, they don't pass it 1 or twice, but at the end they pass it. But this guy didn't. So they sent him, and I'm going to share with you one of the scenarios. And this was a scenario presented in the ER. So they called him to help with a patient with an airway problem. They couldn't intubate the patient. They've already done 3 attempts. So Luis arrives, does a laryngoscopy, no success, backmasks the patient, no talking, no nothing. Another laryngoscopy, no success, backmasks the patient, nothing. Another laryngoscopy. He did 5 laryngoscopies without changing anything. Obviously, Luis didn't pass. And I sat down with him and said, you know what happened there? We told you that we had everything. And he told me, you said to me in the pre-briefing that I should do whatever I do normally. And this is what I do normally. This is what I was trained to do. At the hospital where he got trained, they didn't have video laryngoscopes, fibroscopes, all of that. They were just trained to do straight laryngoscopies, and that's all. So with Gabriela, I felt sad. But with Luis, I felt like angry. And there's more to this story, and there's more to this guy, and I understand that. But at the end, the system failed him. How can we offer a residency program without giving everything? And I asked him about his colleagues, because his colleagues passed the exam. And he said to me, you see, they paid to go to courses, airway courses, ACLS, all that. But in his case, he couldn't afford it. So again, it was a situation of opportunities. And so I approached an airway group that I'm a member of, and I said, we should know how many devices we have at the hospitals in Mexico, how's the situation. So we sent a survey to all the country. We got replies from every state. And these are the results. So they're like terrible, right? I have to make a parenthesis here because private, here you can say big private hospitals where we have everything, but also private means small clinics, privately owned. They don't have resources. But you see, we see this graphic and it's, access to devices. But we also see one thing, and this behind every hospital, represented here, there's a chairperson, there's a director that is board certified. Shouldn't they know that they should have things? What's going on there, right? Are we normalizing? It's the way it's always been. We've always done it like that, so let's keep doing it this way. And actually now people are investing in their own equipment. Residents are buying their own video laryngoscopes and bringing them in their boxes and creating their own airway management cards because the hospital doesn't give it to them. So yeah, are we normalizing? Or are we just validating this evidence? or both. This is something that we know. Not everything enriches clinical practice. So how come people that know are not doing what they should know they have to be doing? So we need to change, and we need to change that, and that change should come from education. Because if it doesn't come from education, it will come from a lawsuit. And it will come from a loss and from a tragedy, and that's not okay. So we know that education has to change this culture. But here's what's interesting. Since 1999, we know that traditional lectures doesn't work for CME by themselves. We need to do more active learning. People have to think more and be more involved in the learning process and not just sit down and receive a lecture. And in 2007, we had the same statistic, and 2015, we have this paper, and it says basically the same. You need more exposures, you need different methods, you need active learning, not just sitting down receiving the information. But if you see last year's Latin American's Conference of Anesthesia, or actually a couple of weeks ago, we had the updated anesthesia course in Mexico City, and you see the program, it is like basically done by lectures. Yes, some few workshops, but some of these workshops are micro lectures. Yes, we have some simulation, we have other methods, but it's like a very few. And now the question is, are we normalizing this kind of education? It's the way it's always been. If I present you the graphic with the airway devices and we presented analyzing conferences, are we kind of doing the same? Or are we just validating the evidence? Or both? At the end is that we are doing the same that we know that doesn't work, and we can see it, and we can see it with the resident coming and not passing the exam. Okay? So here's like my new mantra. No? We have to bring meaningful education to all, meaningful, reflective, that involves more thinking than just sitting down and listening. And I have the best story for this. And this story comes from here, the Stanford manual, emergency manual in the ORs at the hospital, at the ABC hospital. So when I came back from my fellowship, people invited me to give lectures about simulation and non-technical skills. And I always talked about, it's important to have cognitive aids in the OR. It's what we should be doing. And everybody's, yeah. And nothing changed. I approached one of the site chiefs and I said, we need to have this in every anesthesia machine. And he said to me, this is a great idea. You can bring whatever you want to your operating room whenever you come. It's your choice. I don't see how the hospital should be involved. I was like, no, they're not getting it. Until one day that I had the chairman of anesthesia and an OR chief at a CRM course in the simulation center. And I had them leave the MH scenario. And then in the debriefing, we discussed cognitive aids, and I gave them a manual. And the chief said, you know what? I'm thinking we should have one of these in every OR. So at the end, they were, oh, okay, come on. But at the end, we got it. And he said to me, how can I help? And some weeks after, we had it, and this is the newer version, but since the last version, we have one Stanford manual in every OR, and it came not from lectures, years of giving lectures, but from one simulation. So that was fantastic. And we did a little survey a couple of months ago to see how is it doing. And 74% of the people have read it in just while being there in a surgery, and almost 30% of the people have used it in critical situations. I have to say that this statistic is person related, not case related, because some of the cases were the same, where they came in and brought the cognitive aids and they say, yeah, we used it, but it was the same case. But at the end, we've been using it. And actually, there is a case, an MH case that we had at the hospital that went well, and it went well because we have an MH card, because not in every hospital in Mexico we have an MH card. Second, that the attending physician had done her residency with us and she had simulation, but mainly because of cognitive aids. They took out the manual and read it aloud, and everybody did what the manual said, and the patient's alive because of it. So, and everything came from here. But here's the deal. It's fantastic. Simulation is great. We can change cultures through simulation, but not everybody has access to simulation. Actually, in Mexico, we are the only program that has formally a curriculum for simulation for the residency. There are a couple of places that have simulation centers, but they just use it for airway training and ACLS. And in Latin America, it's the same. It's a lot. There's a lot of simulation in undergrad, but there's no simulation for residency programs or for CME. So how do we solve this? Because remember, we need to think in everybody. So during the pandemic, we started reading more and more papers about tele-simulation and remote simulation. And it existed before, but in the pandemic, it got like, okay, this is the moment for it. And we even saw this paper from Chile. Marcia Corbeto and her colleagues published this paper where they proved that you can give feedback remotely and asynchronously and make a change. So it's a wonderful paper. And even this year, people from these places that I highlighted in blue got together and said, you know, this is the agenda that we need to follow in order to research more about telesimulation. This meaning that telesimulation is here to stay. It's a door that's open that I think it will not close. And I'm going to share you my story because I came here to share my stories with WFSA and telesimulation. And they asked me to test this platform. It was a platform made by a company that they said to the WFSA, you know, you can use it. And so I took like a workshop to understand it. And then I used it with our residents a couple of times, with nurses. Then I showed it to the education committee. I showed it to people in Australia, here in San Francisco, to people in Colombia, to people in Switzerland, in Australia. And it was okay. It was a very impressive platform, but it just didn't feel the same as being there in a real simulation. You know, interesting exercise, active learning, yes, but a little bit complex to understand. So we kind of left it there until I spoke to this guy, Andres Diaz from Colombia, and they published this paper. And he explained me how they do the simulations, and we started doing it, and it felt totally different. And I'm going to share with you how it's done. So imagine that some people go and teach another hospital, another country in your global health program. And then you come back here and you schedule a simulation. And this simulation will, everybody gets together in a teleconferencing platform, do the pre-briefing normally, and then you say to the people that is away that they're going to be called for help. So they're not going to be leaders, but they're going to be helpers. Helpers as brains, not as hands. And then you hang up, and the simulation starts. And the simulation is like in a remote setting presented. So imagine that you're in a hospital that has just 2 nurses, 2 surgeons, and the anesthesia provider there. And they're working a case, and suddenly an anaphylaxis happens or whatever. And since there's nobody else in the room or in the hospital, you call for help. But you actually call for help, like video call for help. And then the help is done like telemedicine. It's not usual in anesthesia that we do this kind of stuff. But now imagine that somebody of your colleagues is working at a remote location, and they have an anaphylaxis, and they have nobody to call to, so they video call you. What would you do? You wouldn't hang up.
You hope.
Yeah, exactly, you hope. You would help. And okay, show me the monitor, show me the patient, what are you thinking? Let's bring cognitive aids. So you start working together to solve the case. And that's how it's run. And it's amazing. And in the debriefing, we discuss basically the same stuff that we discuss when we do it live. Basically, it's not exactly the same, but it's close. Now thinking people like Gabriela, we can create a program and bring these people that are out, these kind of active learning sessions that will work, and it means 0 investment for them. Because the investment, we already did it in the simulation center. They just need to have the time to do a call, a conference call. And there's also another thing. What we've been told by the people that we run it with, they feel part of something. They feel listened. They feel part of a community of practice, let's say. Okay, so we get together and do the simulation and discuss it, and then we might chat, and then we get together for online learning or whatever. It's very, very interesting, and it's zero cost for them. And it has an impact. But here's the situation. So we have, in one hand, lectures. Okay, we're going to keep lectures. Lectures give us the base. In the other hand, we have simulation, and then we have clinical practice. Tele-simulation might be a little bit like here. But there's a huge gap between simulation and lectures that is explored. It's being explored. A lot of things are coming out in that area, but that we can explore more, and then that we can search for ways for better active learning. And that area will create, active learning and understanding and comprehending the situation and being more involved in your process of learning. And that's what we are trying to search. And actually, the AMA has a grant that they give every year to innovation in education. But if you see the grants, the recent years, they give it to either big curriculum changes, or technology-enhanced learning, which is great. It's fantastic. Sadly, it's not accessible for everyone, but it's an area that we should also explore. So we followed this advice, and a couple of friends from the hospital decided to create a small group just to start exploring new ideas for teaching and learning, mainly learning. And we created these constraints. It had to be low cost. Low cost because it has to be reproducible anywhere in the world, and because we are paying for it, it has to be low cost. Also, it has to be easy to bring to remote places. It has to be to create active learning, and it has to be original. We have to think outside the box and start searching for new ideas. And I'm going to share you, and I'm going to start with serious games. And serious games are getting more often present in anesthesia. And actually, last year in Euro Anesthesia, they had a track of serious games. And next year at the WSA, we are creating a track on serious games because it had a huge success there. This is the, I'm sorry, Anna. So I'm going to start with this is a very basic one, but it became a very interesting one. She's Angela Enright. Angela was president of the WFSA. She was president of the Canadian Society of Anesthesia, but she's done a lot of work in Africa. And she went there with Lifebox to bring capnographs because in Ethiopia, specifically this was designed for Ethiopia, they didn't have enough capnographs. So they found a way to create some cheaper ones. But they had to come with a course. People need to understand how to read a capnograph. And she said to me, we need to create an experience that is active, it's fun, but there's no money for this. And so the goal or the objective here is to practice recognizing waveforms. So they learned it in a session, in a class, but then they have to practice it. And they had two options. The first option was to have the teacher say, okay, what do you think about this curve? Good. What do you think about this one? Fantastic. What do you think about this? Yeah, you understand me. Half of the room would be away. So we created the Capno Bingo. And Capno Bingo, we just give a piece of paper to the students with the A, B, C, D, E causes of problems with capnography: airway, breathing, circulation, drugs, and equipment. And different causes in each square. Well, it's not a square, it's rectangle. And we just presented slides that we pre-recorded them. Some of them last 4 or 5 seconds, other 15 seconds. And they just have to see the slide, see the waveform, and see to which one corresponds. And the first one that gets one of each in every rectangle, or everyone in one of the rectangles, wins. And it created a fun learning experience. And actually, she came back and she said, this was super fun. I'm going to add it formally to the program. And now it's part of the training program that Angela is in this moment teaching again in Africa. And it's a very simple idea. Plan A is also a game, but it's a card game. So remember Luis, the guy from the laryngoscopies? So it's like we thought about him and people like him. We had to create another activity for a workshop that make people think on different devices. So this is a card game, and you can see here a couple of residents playing it. And you have two decks, an airway card deck and a patient deck. Everybody gets 5 cards from the airway card. And in your turn, you take a patient card and read it aloud. So it's a case. And the idea, I'm not going to explain the full instructions here, but the idea is that you should add the value of your cards, the airway management cards, should be equal or higher than the patient card. So in this case, you have like a Cormac 4, it's a 14. With just a laryngoscope, you can't do it. You have to get more points. You add your experience. Every case gives you experience, so experience is added. And what happens if you don't have what you need? Like in this case, it's a 37, like radiation. You have a laryngoscope, stylet, and sniffing position. You don't have enough points. Well, you call for help. And your colleagues in the table can help you with their instruments. And they will help you in exchange of something, because it's a game. So, yeah, and it's a fun part. So either points or, yeah, I can give you my fibroscope, but you have to give me your awake intubation card or whatever. And it becomes a great experience. And you have also cards like non-technical skills, like you went to simulation, +2 in your experience, or you brought out cognitive aids, +3. And I tested it a couple of weeks ago in the conference, in a workshop, in an airway workshop. Well, I've been doing this since December with residents. But now we tested it with the people that paid for a course, a workshop in airway management. It was super fun. It was a great activity. And we didn't take out anything. We just added 1 table more. And they just rotated through this table. And they were discussing cases. And actually, in a 25-minute period, we discussed like 15 cases. And they said, yeah, you can use your video laryngoscope here, but yeah, add a boogie. And it made sense. So we did a playtest. It's not a formal research. We are starting the research. We just got approved by ethics, so we're going to do a research with interns. But we did a playtest, and I asked about the design of the cards and game mechanics and dynamics and all that. But we also asked these 4 questions. So was it fun to play? And yeah, everybody agreed that it was very fun. Would you play it again? Yeah, definitely. Everybody agreed that it's a good learning experience. Did you learn something by playing? And they feel they did. And do you think this should be included in all airway workshops? And everybody agreed that it should. It was a different way of reflecting, thinking about how would they treat patients using what they have. And I asked an open question. What do you think you learned? And you see 15 of them said call for help. So I think it was very good. And 19 of them said, I can use different devices. By the way, the play test was done on 42 people. So now we're going to start the formal research and to see if actually they learned and what they learned. But so far, it's promising. It's easy to carry. It's low cost. You just print the cards, and that's all. Tabletop vortex. I'm airway obsessed here. No, it had a reason. But if you know tabletop RPGs, this should sound familiar or logical. And the idea is just to reflect on the vortex. So we have a board, and we have minifigures that represent where you're standing. So you put your figure in which part of the vortex are you standing. It's kind of a situational awareness. And you have chips that you put in every place that you went through. So you have only 3 attempts on each. And you have a dice. And then you have a difficulty class. And the patient has a difficulty class, and you have to throw higher. And you see, it's the same that we do, like saying, OK, let's talk about the vortex. So imagine that you can't intubate the patient. What do you do? OK, and now imagine that the LMA is not working well. What do you do? It's the same. But instead of the teacher being the one just saying randomly if they were able to do it or not, you throw a dice. and you just let chance decide. And you have modifiers. So if you throw out 12, but to intubate you needed a 15, then you were not able to do it. But in your next attempt, you might try to do something better and add your modifiers, the vortex modifiers. Okay, so you might say, okay, boogie plus position plus laryngoscope will be +1 each. So now I made it. And you think about your modifiers before. So you think on creating the best opportunity option for that patient in that moment. It's the same, but you just create a different learning experience where they think, and it's pack small, place big. You can bring it anywhere. Now I'm going to move away from the games. I'm going to talk to you a little bit about models. And this began when I was in Bolivia at the Latin America conference, and I was asked to see the patient blood management workshop. And I confirmed what I knew all my life, and that is that nobody understands the coagulation cascade. It is very complicated. And so we needed to create something different than just seeing Roman numbers with arrows. So we thought about models. So the goal here to be understand better the coagulation cascade. And models are not new. And actually we know that people that use either 3D printed models or virtual created models, like in virtual reality or augmented reality, the engagement is better. But you can also create models using laser cutting. And you see laser cutting is cheap, at least in Mexico. It's like 50 cents a minute. So if you have something that takes like 40 minutes to cut, it will cost like $20. So it is not expensive. And then you just have to put it together and paint it. So we created models of the coagulation cascade that they fit perfectly together. So you have a platelet that gets together with von Willebrand factor and collagen, and it activates. And they can do it. And then you have these platelets that can get together. They fit perfectly in the 2B3A, and you can adhere them. And you have the coagulation factors that actually get activated, and you see them because they're just painted. But everything fits. So factor 10 activated with factor 5 activated get together and create this unique form that is more stable with calcium. And then this model fits perfectly in the prothrombin model. So you have prothrombin, and then when you put them together, the prothrombin changes to thrombin and changes its form. And this thrombin fits perfectly with fibrinogen. So you have your fibrinogen, and it will change it to fibrin. And fibrin links together as a chain. And so you can talk about fibrin polymerizing, and then you would need factor 13 to make it more stable. So you just put factor 13 in there, and the situation solved. And then you have the end part, no fibrinolysis. So you have TPA, you have plasminogen, that they get together, changes to plasmin, but it fits perfectly fibrin, the fibrin model part. So here you would talk about tranexamic acid, and in the other parts you can talk about anticoagulants. So it creates a totally different experience, and people don't fall asleep while doing this. It's the same, but it's not the same. And so I just bring residents to the recovery room, to PCU, and just do it. Okay, I'm going to model it to you. I'm going to run it once, and then you run it once, and people, everybody starts collaborating, and then somebody else starts does it again. So we run it 3 times. And then, as I said, we talk about medications, and at the end, we come back 1 week later and just think about it. Yeah, not just the models, but think about it. What do you remember? What do you remember? And you bring back that memory, and they remember better. And we're starting a research now with medical students that had no experience at all with coagulation cascade, so they are not biased. Just to finish, another model would be the LED regional anesthesia feedback model. And this is a very simple idea. In regional anesthesia, you either have to find the target and put the tip of the needle in the target. But we don't normally have or always have a teacher by your side saying, yeah, you did it well or not. So you just create a circuit. And this circuit involves a neurostimulation needle that is connected to a battery. That battery goes to an LED. That LED goes to a plate, a metal plate, that goes into the gelatin model. And whenever the neurostimulation needle touches the plate, the LED will turn on. And you can see it here. So what we are doing now is that we just gave it to a couple of residents that are going to the social service time, and they're going to practice. And this will give them feedback that they're there. And you can put the metal plate at different depths. You can put the metal plate at different widths. And they will send us videos of them practicing. But they have feedback. They know that they did it well. And this is like $1 or less cost. This is the newest model, laser cutter again. It's simple, a couple of inches long, but it gives you feedback. It's just reasonable. So to finish, people don't have the same opportunities, okay? And Latin America is not Africa, but we definitely have a problem of inequality. And this inequality is affecting education, and at the end is affecting patients. And in order to change this culture, we need to create more reflective learning models, where there's active thinking. But these models have to be accessible for everyone, okay? So yes, we need to be creative, and if we need more evidence, we need more people creating the evidence and looking and just searching for these kind of active learning models. So my message here is that you, Stanford Anesthesia Department, changed our culture once. And I guess that there's somebody here that can be creative enough to come and change our culture again. This is a final phrase.